This is pharmaphorum web editor Nicole Raleigh, and I am reporting from Berlin at ESMO 2025. With me today is Dr. Inge Marie Svane, who is Professor in Clinical Cancer Immunotherapy and Director of the Translational Research Centre for Cancer Immune Therapy, or CCIT, at the University of Copenhagen. Pleasure to speak with you today.
Mm-hmm.
So, Inge and I are going to be discussing IO Biotech's new and updated results for IO102, IO103 in the first-line treatment of metastatic or advanced melanoma, non-small cell lung cancer, and squamous cell carcinoma of head and neck. But firstly, Inge, I was wondering if you could describe for viewers your own professional journey to today, and in terms of the research that you do and this recent study.
Yes, so thank you very much for inviting me. Yeah, so I'm a medical doctor, so part of my time I treat patients. I treat melanoma patients, and that is have been my focus for many years. And it's very inspiring in regard to also my research career. So I've been working with tumor immunology since I was a medical student, and knew that this was the most exciting topic within oncology I could figure out. So I've been making a PhD in basic cancer immunology, and after that I've been building my own research center. What I wanted to do with the research center was actually to be able to translate things from the lab and into clinical early trials. So that is my main purpose, and I've been running more than 20 different investigator-initiated trials in that research center. And one of the topics are these immune modulatory vaccines.
Thank you. So if we turn to IO102 and IO103, this is a first of its kind immunomodulatory vaccine that is off the shelf and designed to kill both IDO+1 or positive one and PDL1 positive expressing tumor cells directly and immune suppressive cells that protect the tumor. Most notably, primary results from the phase 3 IOB-013 study was selected as a late breaker, evaluating IO102, IO103 in combination with pembrolizumab versus pembrolizumab alone in first-line advanced melanoma. So Inge, please tell us why these results are so exciting, including perhaps describing first the landscape of unmet need in these cancers.
Yeah. So the unmet need, I believe, in these cancers are actually to try to reduce the level of toxicity as a first line, because we already have very nice combination of checkpoint inhibitors. We can have a response rate of around 50%, but we do also have high risk of serious side effects. And what we saw in the early trial with this vaccine, when we added it on to only one checkpoint inhibitor, were that we could, it tended to increase the efficacy without increasing the high rate of systemic side effects. So that was also why, based on these early data, that the phase 3 trial was developed. And we picked out that it has a breakthrough designation at FDA, and has been discussed with FDA, the design of this study, and it was suggested to add it on to pembrolizumab as a first-line therapy. And I think what is very exciting of the data is that this is actually the first time in metastatic melanoma that we have seen a separation of curves based on a cancer vaccine. It has not been seen in any other studies. So we do see an activity, and specifically we see a very high activity in patients who are PDL1 negative.
Thank you. So when it comes to immunotherapies and translational research in oncology generally, what have been, here at ESMO, the most exciting conversations that you want to attest to?
So the one conversation where I was also engaged was in actually an educational session on biomarkers for response to immunotherapy, but also for risk of side effects. And I think that we are at a time point in the history of development of immunotherapy where we need to consider to select our patients in a better way, so that we can abandon the idea that all patients should receive the same immunotherapy and the same risk of immune side effects, even though they do not have a chance of benefit. And I think we are really developing a lot of different parameters. But what we could also see and what we discussed were that very few of them have been integrated in clinical practice. So what we need to do now is actually to have the validation and also take advantage of the artificial intelligence incorporating many different parameters into a signal of whether this patient should be offered maybe one or kind of immune therapy or combination.
So precision medicine with
Yes.
AI's help, assistance.
Yes.
So
sure.
all things considered that we've been discussing, can you have your crystal ball moment for us and predict or hope what could occur within oncology within the next decade?
Yeah, I think it's already on the run, I would say, because it's moving up front with the neoadjuvant therapies. And we see it in more and more cancer indications that giving the patients immunotherapy before operation. Here you have more to work with because during operation you remove the tumor lesion, but you do also remove all the immunity in the tumor lesion. So if you start out activating the whole immune response within the tumor lesion and starting having the reaction systemically before you remove the tumor lesion, it seems that you will have far better efficacy. So that is what will, I think, continue. And you could, of course, argue sometimes you will have the same efficacy chance in the metastatic setting, but I guess we would all prefer not to have the relapse. Yeah, so it's far better to move out front. But when you are up there front, you also need to consider even more whether you add toxicity on to your therapy. And again, here we might see a benefit of vaccinations because they do not add that much systemic side effects. So it could be a good combination partner. Yeah.
Wonderful. Thank you for that insight, that prediction for the future, and thank you very much for your time today. It's been a pleasure.
You're welcome. Thank you.